extubation. So today we're not going to talk about when or why we would extubate. We're just going to talk about actual extubation. After we get through everything about how to put a patient on a vent, then we'll talk about the process to take them off. So today is just going to be the actual physical act of taking the tube out. A lot of people can do this in clinic fairly soon too, so you may get the opportunity. It's actually pretty simple. So when we extubate someone, what supplies do we need? Technically, we need our re-intubation supplies. We're not going to necessarily put them in the room with the patient. Hey, we're putting all this over here in case we got to put the tube back in. But you do need to realize that they need to be close by, because some patients who we extubate, they don't do well and they have to be re-intubated. So you'll just verbalize that you need your intubation equipment. I'm not going to make you tell me all that stuff again. We need a towel, because we'll put a towel right here. Can you grab me a towel from the, never mind, Aaron's gonna get it. Thank you. Yeah, we'll just use a paper towel. You guys pass that to me, please. Thank you. So we're gonna put a towel here, because when we take the tube out, this is where it's gonna end up. And so usually it's like those blue chucks. They're blue and shiny on one side, and they kind of have the white absorbent material on the other. So you can just put one of those there. Let me shut the door. Yeah, thanks. We're trying to get the gas put back in so we can have our vent back. Which after probably today, you guys will be able to go in there if you want to start practicing, because next week we're going to start on the vents, and I'll give you your assignments too, so you'll know what vent you're going to start out with. So we need that. We need a syringe, of course. We need our cool air mist or a nasal cannula. A lot of hospitals now just use cannulas post-extubation. I still think a cam is the best option, so you need to have, for our purposes, so I know that you know how to set one up, we're gonna have a cool air mist available. Remember, large volume corrugated tubing and a mask. Please be somewhere where you can see. I'm serious. You can't see if you're standing behind somebody. Thank you. And if you can't see what I'm doing, then you can't learn. So I think that's all the supplies that we need. Oh, you do need to have racemic epinephrine available. Again, it's not something that we can carry with us. We used to be able to just carry drugs in our pockets. It's going to be in the Pyxis, but you need to know that you need to have it, that you might have to use it afterwards. So what's the dosage of racemic epinephrine?
11.25.
11.25 milligrams. It's a 2.25% solution, so sometimes you might see that as well. That's just the percent strength. The actual dosage is 11.25 milligrams, and how do we give it?
SCN.
Via nebulizer. Apparently, before now and last term, a lot of people thought we gave it by IV.
That's what I thought.
I know. It's not epinephrine, it's a variation of epinephrine. It's racemic epinephrine. So you need to specifically say racemic, because it's a different type, and it's done by small volume nebulizer. So we're going to aerosolize it onto the vocal cords to help reduce stridor. Okay? Any questions so far? Okay, so we're ready to extubate our patient. We're going to tell them what's going on. Most patients, unless we're doing a terminal extubation, which would be an end-of-life extubation, the patient will know, like we've been doing weaning trials on them all morning. We've been letting them spontaneously breathe on their own. We've told them that, hey, we're gonna let you breathe on your own, see how you do, if we can take the tube out. They'll have been doing that probably for a couple hours, and you'll be like, okay, ready to go. And the patient's gonna be like, yay, thumbs up, ready to get the thing out. So it's usually not a surprise. Remember, if your patient is a coroner's case, we do not extubate.
Right.
So we never extubate without a doctor's order. Don't do it because your nurse tells you to. Got it? The nurse is not the doctor. And if you extubate the patient and there's no doctor's order, it's your butt on the line. Sharon, did nurses try to tell you to extubate?
Oh, yes. There's one or two that would be notorious for it, but you learn. You're like, oh, wait a minute. So yeah.
You need to actually see the order that it's been written, or you hear the doctor tell you themselves, and then you can write a verbal order. But otherwise, you don't extubate. That can come back to bite you, especially if the patient doesn't do well. The doctor will be like, I didn't say to extubate the patient, and you never got the order from him, so he really didn't tell you to extubate, so don't do it. The other time nurses will try to tell you is if a patient is dead. And I know it seems silly, but you still need to order if the patient is dead, because you're still removing the tube. And the reason is because of the coroner's case. We've had some RTs that they went by the nurse who said to extubate the patient, and then the patient was a coroner's case. Why is it important to not extubate in a coroner's case?
See if you're the one that did the damage?
Yeah, I mean, but when they become a coroner's case, they're going to the coroner to have an autopsy done. And so everything has to remain in place. Generally, it's patients that were in the hospital less than 24 hours or suspicious death. If they're in the hospital less than 24 hours, we might not necessarily know the cause of their death because they were there for such a short time. So a coroner's case has to go to the coroner with everything in place so they can make sure everything was done properly and it wasn't our fault that the patient died. So a coroner's case, the ET tube will stay in place. So don't be the one to extubate them. So that's a bad day too. So we need to order, make sure it's not a coroner's case. For terminal extubations, you know, as students right now, you can't actually take the tube out. You can be in the room though, so I would advise that you see when you can, if the hospital will let you, because it's good to see how that is. It can be very overwhelming. So it's better to experience that for the first time as a student, and it's overwhelming if family's in the room. Usually a terminal extubation, there's a lot of family in the room. They've made the choice to withdraw life support, and you're going to have to be the one to take the tube out. So you guys can see that process. When you're actually licensed, you'll be the one to actually take the tube out, extubate to oxygen, or maybe not even anything. Patients don't always die as quick as we thought they would either. The other thing you might see at end of life is organ donation. So, and when you get to term 5, we'll have the group from the organ donors come in and talk to you about that whole process. But patients who are organ donors, we're not going to extubate them because they're going to need to go from the ICU right into surgery to harvest, what they call harvest their organs. And so there's a whole process that's done that. Very few patients actually qualify for organ donation. There's only 2, you have to be brain dead, completely brain dead, which involves a variety of tests. And you need to have consent. If the patient has signed up as an organ donor, then you don't need family consent, and actually they cannot override that. That's the one thing that they cannot override.
The family can't override?
No,
okay. Because
the patient's registered as an organ donor, so it's not the family's decision anymore. But if the patient isn't registered as an organ donor, then it's the family's decision on whether they'll do and if they qualify. And then they call the organ donors in, the group, to come in. The other one's donation after cardiac death, so that's when the heart actually stops. And there's very strict criteria that has to be followed. So most of those patients actually don't qualify for organ donation. That's why we don't have a lot of organ donors. There's a very strict process that has to be followed. But anyways, so other than that, we're gonna get ready to do our extubation. So explain to the patient, very simple terms. Okay, Mr. Joe, we're here. We've got the doctors okay. We're gonna take the tube out now. So we're going to sit you up. So the first thing you have to do is sit your guy up in semi-Fowlers. Want him to be nice and elevated. If he scoops down in the bed, you need to get him up in the bed. We want him to be able to breathe well. Don't be squashing down on the diaphragm. So you're going to have to do the suction process one more time. Don't forget your 100% O2 button as well anytime you're suctioning. Some RTs out there get lazy and say patients don't need 100% O2. They don't get hypoxemia. They're fine. Well, how do you know? Have you ever had an ET tube in? I've talked to patients that have had ET tubes in, and they said the worst thing that's ever done to them is suctioning. And it makes them feel like someone's sucking all the air out of them. Just give them 100% oxygen, please. It's a button. Don't be lazy. Push the button. It's not going to hurt anything. So push the 100% O2 button. You're going to suction out the mouth. And these are all the things you need to practice. And we're actually going to get the suction machines out today, so you guys can practice actually suctioning and hooking up everything and seeing how all that's done. We have a whole load of them over there next door. So yank our, suction out the mouth, We're gonna suction out down the back of the throat as much as we can. We wanna try to get all those subclottic secretions out, the secretions above the cuff. Just suction down the ET tube one more time, one last time, promise. Have to just do it one last time before you can get the tube out. Okay, so now as far as all this goes, we're gonna just cut this because we're gonna take the tube out anyways. You guys have scissors in here?
Nope. There's scissors in my bag
I think
underneath
you
where.
used these last time. Let me
Underneath.
see. I might be able to
Underneath
tear
that.
it. Yeah, I can tear it. Never mind.
Okay.
So you don't need to tape it from the ET tube. The ET tube's coming out. So, and depending on your patient's skin, please be careful when you're taking the tape off. Now we want this tube to come out on our terms, so you're still gonna hold it because we want the cuff to be deflated. The last thing you have to do before you take the tube out is what we call a cuff leak test. And a cuff leak test, oh hi, and I didn't think you were coming.
Mentioned.
In a cuff leak test, what we're doing is taking the air out and we want to make sure we hear a leak. So I'm still holding on to the tube. I'm going to take the air out. And if I'm hooked up to the ventilator, which I am going to be, then you'll hear a leak. And like I said, I can't explain it. It's a gurgling sound. You guys will know it. You'll hear it too if somebody doesn't have air in their cuff at some point. So you'll hear the gurgling sound. You'll also see what you'll learn is your tidal volume on your ventilator will drop down. The tidal volume is just the volume of air we give with every breath. So what goes in should come back to the ventilator if there's no leak. We just made a leak by deflating the cuff. So you'll also see that the air coming back to the ventilator is decreased as well. That it should be if you just made a big leak. So you'll hear it and you'll see the numbers drop on the ventilator. That tells me my patient can move air around the endotracheal tube and they don't have airway swelling. Does that make sense? Mm-hmm. That's called a cuff leak test. You guys do not need to order. It's a very simple thing that you can check. Probably should have done it actually before I untaped it, but it is part of extubation. If you do that and you don't hear a leak, the tube is not coming out whether the patient's ready or not. Because if you take that tube out and you don't hear a leak, that means the patient has airway swelling. And as soon as you take the tube out, they're gonna have massive problems breathing. So cuff leak test is a deal breaker when it comes to extubation. So make sure that they pass it. By passing it, we mean that we hear a leak. So do it before you untape the patient. Don't follow my sequence here. Because if the patient doesn't pass, we can't extubate. So we did our cuff leak test, then we untaped. The doctor may even ask too, did you do the cuff leak test? Did they pass it? Especially patients who maybe had anaphylactic shock, upper airway surgery, maybe some kind of swelling going on. It's definitely need to check it. Very simple and easy thing to do. So now we're ready to extubate our patient. We're going to take our syringe, pull all the air out, tell our patient to take a deep breath in and cough, 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 pull the tube out. You'll set it on there. If you take the OG tube out, you'll put it there too. Take it and get rid of it. You leave the vent on standby in the room, usually for about 30 minutes. Because you need to make sure that the patient's actually going to tolerate being extubated, and you put your oxygen on them. So for us, we're going to put the cam on. You can just use the same FiO2 they were on the vent, usually 30-35%. And then you're going to monitor your patient. You're going to listen over the trachea. What are we listening for? Stridor. Listen to breath sounds, check your vitals, all that good stuff. If you hear stridor, mild to moderate, which means your patient's not in a lot of distress, but you can hear the stridor with the stethoscope, or maybe a little bit of audible stridor that you can hear. Your patient can move air, and you'll know the difference, and they're actually breathing. Those patients get racemic epinephrine. And if they're not on a cool mist, they need to be. So say you're at a place we extubated to oxygen, patient has stridor, you're gonna give them the racemic epi treatment and put them on a cool mist, because that will help. patients that have marked, the word marked is very important, also known as severe. Marked is just another word for severe, but our boards love to use the word marked. So, marked or severe, anything, whatever is put with that word is life-threatening. It's bad, bad, bad. Marked retractions, your patient is in a bad state. Marked stridor means the patient is not moving air now. The stridor is so bad and the inflammation is so bad, there's no air exchange happening. Again, it's just one of those things you have to see. But trust me, you'll know your patient can't breathe right now. Yes?
So even though you did the cuff test and there was no swelling,
Some people still have stridor.
Some can develop the marked stridor afterwards. Okay.
Just because they have a crummy reactive airway.
Okay.
Yeah, I have a crummy reactive airway. I get stridor from choking every once in a while. It's not fun. So if you've never had stridor, and never not, you have no idea what fun you're missing. But you'll know it when you hear it. It's this crazy, loud, high pitch. I can't even do it. Some people can. I don't want to do it because I've had it. Super high pitch. Patients can't breathe. You can see that their chest is moving. They're trying to breathe, but there's no air movement. They will look scared. They'll be desaturating. Their heart rate will go through the roof, like big time. So you'll know what those patients need to be reintubated immediately. Now, this is kind of like what you'll learn when someone goes into V-fibrillation. V-fib, we defib them, we shock them on the chest. And people will say, well, aren't you gonna do CPR while you're getting the stuff ready? Yes, you are, but the ultimate thing that the patient needs is to be shocked on the chest. When we're re-intubating, it's the same way, because you're not gonna have re-intubation equipment actually up and ready to go, you're gonna have to get it out. So people are like, well, what are you gonna do in the meantime? You're just gonna stand there? No, you're gonna try to ventilate. You won't be successful, but you're gonna try anyways. But the ultimate solution is the patient needs to be reintubated. So if your patient has marked stridor, you need to reintubate. That's the ultimate solution the patient needs. Yes, you will try to bag them in the meantime and try to ventilate them in any way you can. But when you see that option on a test, that is not the right answer. Because bagging them is not the ultimate thing that needs to happen. Reintubating is. Does that make sense?
Yeah.
So you'll see questions like that where they want to know what needs to happen to fix the problem, not what's going to be the interim. So if your patient has marked stridor, reintubating is what needs to happen. I know a couple people have questions.
Do you need a doctor's order to reintubate after?
Yeah, I mean technically, but you're going to call a rapid response or a code, and then they're going to have the staff that you need there.
So your job in the interim then would just to be bagged while you call the code.
Yep.
Okay.
Scream for help in the ICU. Yep.
So the doctor will say, I want these to be extubated, and then on his little tiny way.
because we extubate the patients all the time.
Okay.
We don't have a room full of people in there when we're doing that. Maybe you'll have the nurse come in, maybe you won't. But if the patient immediately goes into marked stridor, you're going to call everybody back in there to help you.
Okay.
So, did you have a question?
Yeah. Do you give them racemic epinephrine even if it's marked? No,
No.
you just re-intubate?
Won't help.
Well, with the swelling and everything, can you actually reintubate?
Good question. It depends.
Wouldn't you go to
You might.
Okay.
It's going to be a very hard reintubation if you can get them intubated. One thing that we can use, and again, we'll talk about this next term, but we need a bougie. Yeah. Oh, well, do you remember what the bougies are? Do you know? It's the long blue. Looks like a big long stylet. It's blue. Can you go grab one? You'll see it. Mr. Rutherford maybe can show you. I think it's open. Yeah. Yeah, it's open. The SimLab's open. So I'll show you how we could actually, in that situation. No, Moel, SimLab. Nothing's put away yet. Yeah, it's down in the SimLab. We don't have anything put away yet.
No,
Are they still giving you a bad time?
no. Always.
So the thing that can be done with Mark Strider is re-intubating. It is going to be a question of whether it can be done. It's a very hard re-intubation. Typically your patients will desaturate very, very low. The other thing you could do is get a paralytic on board to try to stop the Strider. Because when you paralyze everything, hopefully you can stop the spasm.
Did you do a sedative before that paralysis?
Oh yeah, thank you. So if you can't get an ET tube in, the other thing you can try is to use a bougie. This is a bougie. It's B-O-U-G-I-E. On the test, they'll call it an endotracheal tube exchanger. So we don't use they don't give anybody credit.
What exchange?
Endotracheal tube exchanger. Because that's what it's really made for.
And then you said how you spell the bougie? B-O-U?
B-O-U-G-I-E. Bougie.
Bougie.
So what the bougie is really made for is to exchange an ET tube. So we need to get a different size, or the cuff is blown or something. If this is in my patient, this is like a placeholder. So this will be put in. It will be in the vocal cords because it's gone through the tube. And then I take the tube out. And this is still in place. And then I get a new tube and I put it over it.
30 seconds still.
And put it in. Yeah, it's actually really quick. Put it in, it's already in place. Take the old tube off, put the new tube in, take the bougie out. Voila.
Some medical shows they show that kind of doing whenever they're doing the initial intubation.
Well, and that's what I'm going to talk about. Yeah. So if you need to and you have a hard intubation, you can actually use a bougie first. So get this through the vocal cords. You can't get an ET tube through. You can get this through and then slide your ET tube over it. Now your patient's intubated and you can take this back out. So in a difficult intubation, which a Mark Strider patient would be, you could actually intubate with the bougie first. And some doctors actually do this. It's not why you saw it on TV, but some doctors actually put the bougie in first and then will slide their tube over it. Because if this has gone in through the vocal cords, the tube is also going through the vocal cords because it's just a placeholder. And then you take it out. So that's another option as well. But for purposes of Mark Strider, re-intubate. Mild to moderate, racemic epinephrine, and a CAM.
So when you're extubating, is there 2 RTs with you, or are you just by yourself?
A lot of times you're by yourself.
Okay.
Or the nurse,
Yeah, the nurse will come in. Yeah. Yeah, it's not uncommon to have the nurse. That way you have someone else in there in case things do go bad. So she's gonna know that the patient's getting extubated as well. Yes.
And it kind of just depends on the hospital, because that's
Yeah.
there's only one RT on at all times.
Yeah, you're right.
So for an intubation, there was the manager there and the RT, and then the manager left, and then it was just you and the nurse.
Yeah, smaller hospitals, there's only one RT in the whole hospital. So you're it. Yep. Did you have another question?
Oh, no.
Oh, okay. You're it. And then if there's 2 of you, you got 2 codes going on. You have a patient come into the ER. That's a code. You got an ICU patient that coded. Guess what? You're both in the codes.
Okay, so in that case, if you're the one and only RT and you are coming into a code, does the nurse help get all the equipment out while you're bagging?
Yep. The
Okay.
nurse will help. Yep. And you might be the one intubating if you're at a hospital that lets RTs intubate. So you're going to see that there's more and more, especially the smaller hospitals. There's not people there in the middle of the night to intubate. You're it. So if somebody needs to be intubated, you're it. If a baby needs to be intubated, you're it. You're the one that's doing it. So you got to be well versed. So we will go into more about difficult airways next term. So otherwise, you're going to monitor your patient. That means monitoring breath sounds, vitals, all of that. And you're going to need to keep a closer eye than normal for the first 30 minutes or so. You also could extubate to BiPAP, which we will also talk about when we talk about actual weaning. But if you have a patient who is maybe just so-so, or you have a COPDer and you don't know how he's going to do, you might have BiPAP on standby, or they might say extubate to BiPAP. Just go ahead and put them on BiPAP as soon as you extubate. So you wouldn't use your CAM in that instance. Monitor your patient, make sure they do okay.
So are you literally just gonna stay in the room with them for 30 minutes?
No. So you're gonna, in your ICU, you're gonna have other people. If you're the only person, then you have to rely on your nurse to help you because you might have to go somewhere else. But in those smaller hospitals, I'm going to assume that you're all gonna work together, just like you are in bigger hospitals, but you have to rely on each other even more in a smaller place because there's not as many of you. But in a perfect world, you're gonna be in your ICU, there's multiple people on ventilators, so you're gonna take care of your other patients, you extubated, and you get, what you'll need to get in the habit of doing is kind of like, you gotta go from room 1 to 3 to 5 to 6 to 7. Well, say we extubated the guy in room 3. As you're going through and seeing all your other patients, you can check in on 3 as you're going by. And that doesn't mean you have to actually go in and bother the patient. It could be as simple as just looking in the room. Is their family there? Are they talking? Are they having a conversation? Are my vitals good? Does my patient look comfortable? Or does my patient look in distress? Then I need to go back in and see what's going on. It's gonna depend on the situation, but you'll be able to watch him or her as you're going through and looking at everybody else, which you should be doing in your ICU anyways. I always make it a habit of just checking as I go past each of my patients, just to make sure, checking in. I was in the ICU at Kaiser South one time. I'll never forget this guy. I was there as a preceptor, or the clinical instructor. One patient, so I go walk in and there's a patient in the corner, and you go and you look at him and his non-rebreather's sitting on his forehead. And his stats are like 78%. They're going off, and the nurses were somewhere in another room. And I look at him, and he looks at me, and he does this. It was the funniest thing. I was like, good job. And then we had another lady down at the other end. She's trying to climb out of bed. Her nasal cannula is on the bed. She's trying to climb over the railing. I'm like, what are you doing? Her stats were dropping. So it's fun times. So you gotta pay attention to what's happening. Even if your patient's not on a vent, there's a lot of things happening in those other rooms. Sharon, you have anything to add?
After I extubate a patient, a lot of times I'm in the room just making a note in the chart, patient extubated to 2 liters nasal cannula, tolerated well, no respiratory distress. You're kind of organizing stuff, making sure you tell them, don't talk too much because you want to rest your throat. Notoriously, you'll take the tube out, the first thing they'll say is, I'm so thirsty, can I have something to drink? No, the nurse has to do what we call a swallow eval. That tube's been in there, so we want to make sure, and this is what I tell them exactly. I say that tube's been in there, so you want to make sure when you get something to drink, it actually goes into your stomach, not to your lungs. So they can't have anything to eat. Even ice chips, the nurse has to do her swallow eval. So in that time is enough for me to assess and see, are they going to do okay? If so, then I feel comfortable moving on to my next patient room. Some hospitals you're supposed to take the vent out within an hour of them being extubated. Some you leave it in there a little bit longer because you're a little bit on the fence if this person's gonna really fly or not. So it's usually, maybe 10 minutes or so that I'm in there doing all this stuff, and then I feel comfortable enough moving on to my next patient.
And while you're not gonna take the vent out, you are gonna put the circuit up and cover the end of it. I don't like to leave it open. And then push it back a little bit so it's not right on top of the patient. So if your patient is gonna do fail quickly, you'll know within that time. Because some patients will fail within the first 10 or 15 minutes, or some are even less if you have that patient that gets the Mark Strider. Some you might not know for an hour, hour and a half, you thought they were gonna do okay, and 2 hours later they're pooped out and need to have something going on. So one thing you'll learn when we talk about weaning and extubation further is there's no magic numbers, there's no magic formula that says a patient is gonna do well. Yeah, we can extubate. We're gonna look at all the values and we think we know. We think they won't have stridor, but sometimes they have terrible stridor. We had a patient who actually had to get trached because we tried to extubate her 3 times, and every time she had severe stridor and had to be immediately reintubated. So she ended up having to get a trach. Other patients, you might think they're not gonna do well, and they do great. So you monitor all these parameters, and you get all these numbers, and the patient looks great, like they're gonna do really well. And 20 minutes later, they're huffing and puffing, and their rate's high, and they need to go back on the vent. And then you have a COPDer whose numbers were marginal, and you thought, I don't think he's gonna make it, but we gotta try. And then he does fine. Or you could just have your average Joe who is kind of iffy, you don't think he's gonna make it, and then they do fine. So Sometimes we just extubate to see how our patient's gonna do, because we need to determine, are they gonna come off the vent, or are we gonna trach them and they're gonna stay on the vent? So, sometimes it's a guessing game. We try to do the numbers the best we can, but you never really know until you take the tube out and you see how they do. Okay, any questions? Anything else, Sharon, to add? Did I miss anything? Okay, one thing before we go, do you want to show them how to do sterile? I have one that is, nope, I'll go grab you one while you